Thank you for joining us for Season 4, Episode 3 of Doc Talks with Dr. Forrest Tennant and friends. Thanks for being with us tonight, and we appreciate you all tuning in with us. We have a great show ahead of us. Thanks so much, and Doc, it's all yours. Please take it away.
Okay, well, thank you very much. I'm glad we're getting started here. What I want to do to start off our show tonight is to talk about pain perhaps different than it's been talked about in centuries. I want to give you a quick brief history. Since time began, physicians have noted that there's a group of chronic pain patients who are special. Today, we usually call those patients intractable to indicate they have severe pain, they need potent medications, but this is not new. This has gone on for a long, long time, and you can find references to this subgroup of chronic pain patients even in the writings of Hippocrates in the years 4000 BC. Now, this subgroup of chronic pain patients has been assigned different names over time. In recent times, we've called various people in the last 20 years have called this subgroup persistent pain patients, central pain patients, neuropathic pain patients, high impact pain patients, and I'm sure neuropathic pain patients. They've assigned them different numbers, but the bottom line is this is a special group. Now, I thought I would show you something. In the 1700s, there were two famous world physicians. One was an American known as Benjamin Rush, and he was in Philadelphia, and the British famous physician was a Dr. John Fothergill. Now, I have here in my hand Dr. Fothergill's book written in 1781. And he makes a very, very interesting comment about this interesting group of patients. I'm actually going to try to show you his picture here. This book is not 100% preserved, but it's not in too bad a shape. But there is a picture of Dr. Fothergill. Now, what's fascinating about this is that he actually was a doctor. He was considered the top of his day, and he tried to treat this subgroup of patients, believe it or not. And he called them persistent patients, persistent. And he also made the comments that they were complex patients, and therefore no doctors wanted to see them, so he would. Sound familiar here in this century and in this year? I mean, in other words, he's writing in 1781, he's calling this group of people persistent, and other doctors don't want to see him, so he's going to make a shot at it. He actually describes, he didn't call it arachnoiditis, but he actually describes a patient of his that had to have adhesive arachnoiditis, had all the symptoms of today. And so I want to call your attention to this because a lot of this isn't new until now. Now, what is new about research is there are several things. The decade of pain and the 1 to 10 scale may be gone. We may be a much smaller group, but nevertheless, there's been a lot of dedicated people trying to deal with this subgroup, and I know that's who primarily watches this show. And most of you who watch this show, you have arachnoiditis, you've got a genetic collagen deficiency, you've got CRPS, you've had head trauma, you've had diabetes, you've had a lot of these causes of this persistent or what we call intractable pain patients today. Now, one of the first discoveries about this group of patients occurred some 10 years ago when it was learned that a cell in the brain and spinal cord called a glial cell produced inflammation. Now, no one knew why it caused this inflammation, but at the same time, it made it clear that it occurred in this subgroup of people, and a lot of brain scans were done showing that tissue had been destroyed or made dysfunctional on brain scans in these individuals who had what we call intractable pain and whose studies in rats and other people showed that it was caused by inflammation, brain inflammation. Now, that was a new concept 10 years ago. Okay, and so what has transpired since then is that it is time that everybody watching this, including physicians who take histories or nurse practitioners, chiropractors, anybody who deals with patients, the time has come to subdivide intractable pain or persistent pain patients into two groups. And it's primarily based on constancy. Here is the term that I want you to grab right now. The term constant pain. In other words, is your pain there or is the patient's pain there 100% of the time except when they're asleep? And if the pain's persistent, you're likely to have to take something to sleep to go to sleep. Okay, constancy is the name of the game. Now, there are two kinds of constancies, actually, one hooked onto another. Now, you hear stories about we have, a few million people with chronic pain. Yes, but those are what we would call intermittent cases. Now, a lot of people have arthritis. They've got little neuropathies. They've got bunions. They've got carpal tunnel. They've got different kinds of pain, particularly if you get older. I can testify to that, that you're going to have intermittent chronic pain. Now, in this group, you may also have some people who develop constant pain, but it's mild. It's not overwhelming. You don't have to take a potent opioid. You don't even maybe have to take medications every day. So your first category is either intermittent or periodic chronic pain or mild constant pain. That's group one. Group one. Now, group two, severe constant pain, medications every day, you're disabled, you're bedbound, your life is ruined, you can't think, you can't eat, you can't do anything. Those are the people today that we normally call intractable. Now, what I want to segue to real quick is what causes the constant pain. Now, the reason I say this is a little new is because you're going to hear something that I've never seen written or talked about until just lately, and that is what causes constant pain. Well, there can be three reasons. Three reasons. And everybody watching this and everybody you talk to needs to ask themselves these questions right now. If you've got 24/7 pain and never goes away, why do you have this? What's different about your body from other people? And keep in mind one other thing. It's mystified doctors for centuries. Why can two people with the same disease that looks like the same pathology, the same everything, except one patient's got severe constant intractable pain and the other people takes a little aspirin once in a while? Why? That question has plagued doctors for centuries. Well, now we've got some answers. Now, first off, what are the three reasons you can have constant pain? Well, first off, you can have what we call nerve entrapment or nerve destruction. Now, a lot of people don't quite know what nerve entrapment means. That means that you have a nerve, and for example, let's just take a nerve, one of the sciatic nerves in your leg, or maybe in your arm. And that is that around the nerve, you've developed fibrosis, scarring, and it has trapped that nerve or group of nerves, or it's been destroyed by trauma. And so consequently, the body's natural flow of electric currents can't pass. Okay? So entrapment means electricity can't pass. The normal flow of electricity is generated internally and goes down the legs to go on out into the air through the toes and the feet, or through your ears, the tip of your nose, or your hands. In other words, you generate electricity in the brain or in your internal organs, and it flows outward. If you get an entrapment, the electricity backs up, that's pain. That's why, things like acupuncture or a magnet or a massage may allow some electricity to pass that entrapped or damaged area. Okay? Now, for your information, arachnoiditis is an entrapment disease. The cauda nerves glue themselves to the lining, the canal, spinal canal lining, and it forms a mass that entraps cauda nerves. So remember, adhesive arachnoiditis is an entrapment disease among other things. Okay, so entrapment. Now, the second reason you can get constant pain is that some process in your body, and we now think it's what we call autoimmunity, destroys the small nerve fibers. And on the show in the past, you've heard us talk about small fiber neuropathy. These small nerve fibers in your skin, and there's a lot of them, for example, at the bottom of your feet, in your mouth, in your crotch area, and those small nerve fibers get damaged and they may disappear. If they disappear, guess what? You have the same problem as you do with entrapment. Electricity is backed up. That's going to give you constant 24/7 pain. Okay? So those are the two of the three reasons you can get constant pain. Now, the third reason is in the brain and spinal cord itself. And that is, there is a mechanism inside the brain and the spinal cord, and scientifically, but actually the lay public's catching on to this, we have these glial cells are attached to something in there, some little microscopic things called receptors and neurotransmitters. In other words, pain inside the brain is controlled by something we call scientifically neurotransmitter receptor systems. And there's about 7 different ones. The major one's is endorphin. That's the neurotransmitter, and dopamine and GABA and serotonin, cannabinoids, things like this. And what happens is that you can get inflammation or damage like a stroke in the brain, and it damages or knocks out enough of these neurotransmitter receptor systems that it no longer can function properly and shut down the pain. In other words, the body's natural God-given biology is that we have these systems in the spinal cord and brain to shut down pain. So if you've damaged enough of those things inside the brain or spinal cord, the pain stays constant. Let me repeat. You can have 3 reasons to have constant pain. That's why it's far more important to know whether you have constant pain rather than whether it's chronic or persistent or periodic or anything like that. Is it constant? And it can do due to 3 reasons. Nerve entrapment or destruction, small fibers that have disappeared and can't conduct electricity, or thirdly, you have neurotransmitters or receptors in the brain and spinal cord that have been damaged or disappeared, and the pain will no longer shut down. So right now, anyone watching this, and when you talk to your social media groups and your doctors, try to figure out which one, or do I have more than one reason for my pain being constant? Okay? So now, what do we do about it? That's going to be a subject for another day, but we at least now know the 3 causes. We know what to now to look for. The first step in finding some help, some amelioration, some cure, some relief is what's the cause? Well, we know now what causes constant pain, and we're getting some treatments for all 3 of the type of constancies that is out there. So that's your basic, it's a little scientific, it's a little hard to understand, but I think if you think about it, it's not all that tough. We're going to talk about each one of those things periodically over the next few weeks, but that is it. Again, in summary, if you've got pain 24/7, does it come and go, or is it mild? If that's the case, you certainly don't need the potent pain treatments you're going to need. If it's severe, constant, putting you in bed, you can't think, you can't eat, you can't function, that is we call that severe intractable pain usually right now, but it really should probably be called severe constant pain. You know, the whole world knows Rhonda, so we know about her and what have you. And Rhonda has been telling me a little bit of a story. She's one of the people who has taken the time and the diligence to study, find their good doctors, and actually share a lot of great things with it. Rhonda, this morning you told me a fascinating story, not so fascinating, but one that I'd like to hear because you've got multiple doctors that you personally attend, and you've got a very comprehensive program. And when I first met you, I never thought you'd be doing as well as you are today. And so I'm delighted
Me neither.
Rhonda, tell us a little bit. I know about you'll be some people here who don't know your background, but again, the story you told today is one that I hope is repeated in every community and every medical clinic in the country. Take it away. What happened to you today? Or the story you told me today?
Well, as I told you this morning, Dr. Tennant, excuse me, I saw one of my numerous doctors, and within this physician's network, she sees that I see another doctor. So she asked why I was seeing the rheumatologist. So I explained to her, reminded her, because usually I see a PA in her office. So anyway, I reminded her that my rheumatologist is seeing me for, keeping track of my blood labs, the cytokine levels for the inflammatory process, and a number of other issues that deal with my underlying disease, which is adhesive arachnoiditis. Well, it just so happened that she had a medical student in with her in with our appointment this morning, and she said, well, would you mind telling this young man here, he was about 25, 28, 30, somewhere in there, would you mind telling him a little bit about adhesive arachnoiditis? And I said, yeah, absolutely, I would. So I just went into an explanation of, what it is, that it is a neuropathic, it's a complex neuroinflammatory disease of the spinal canal, where the nerve roots in the cauda equina stick together and they form adhesions, and they can form adhesions together or they can form adhesions to the outside covering within the dura. And these images can be seen on an MRI. And when I had this injury of an epidural steroid injection, it was a number of months later that led me to Dr. Tennant. The physician I saw this morning is familiar with Dr. Tennant's name. I've given her a number of his books on the topic. And I told him that I went to see Dr. Tennant. He diagnosed me with adhesive arachnoiditis, a 3-step protocol. Who the other doctor that was mentioned, my rheumatologist, is now prescribing for me. So he asked a little bit about that, like what's involved in your protocol. So I told him, the suppression of inflammation, and the neuroinflammation with depomedrol injections, ketorolac injections. Can't remember now exactly what all, but I did list a number of other things. So anyway, I went into the part 2 of the protocol, which is to regenerate nerves within the cauda equina. So he was kind of fascinated with that one as well. And I told him that it is progressive if it's not caught and treated early enough. And I'm fortunate enough that, and I did tell him, Dr. Tennant, that when I first saw you, that I was bent over a walker and you told me we're going to dump that thing. And we did. And here I am. And that of course led into a discussion of what I do to stay active, which is gardening, butterfly gardening, vegetable gardening, et cetera, et cetera. But then the number 3 part is the pain control. And that plays into that 3-component plan that has allowed me to have my life back. And it's all because of Dr. Tennant. So if my name is known, it's only because of you, Dr. Tennant. So thank you very much.
Very, very good. All right. Well, again, you make a point that at this time, some of these painful diseases fall in the cracks of medical specialties. Okay. And I'm going to talk a little bit about why that's happened and why that's one of the reasons on why patients who have severe pain problems, constant pain problems, can neither find doctors nor find anyone to prescribe, is because the diseases that cause severe constant pain are not well known. They continue to be somewhat unusual. They're not considered rare necessarily, but they're certainly not as common as asthma or peptic ulcers, for
Right,
example. And so you're going to,
right.
like in your case, do you see a neurologist, just a rheumatologist, family doctor, a surgeon, a pain specialist? Who do you see? How many different doctors do you see?
I see a rheumatologist, which is basically taken over my primary care physician spot. I see a pulmonary doctor, which is who I was at this morning, because I've had a node on one of my lungs since when I was 20 years old. So they just keep a constant eye on this. And I see a pain management physician. And geez, I think I feel like I'm forgetting someone. That may be it. But yes, this gentleman here, he'd never heard of adhesive epidermolysis. So he was thankful for that little, 10-minute education that I was able to give him. And I was thankful for the opportunity that my doctor asked me to tell him about.
Right. Very good.
Yes, if we have a minute,
Go
I
ahead,
would
please.
beg your indulgence. I had a little something I wanted to share with people before next week about our bodies, because I hear a lot of people feel like they're at war with their bodies and they are angry at their bodies. And I just want to put in a good word for our bodies, because to me, they're also an important part of creation of God. And our bodies suffer with us. I don't think they do these things to us on purpose. And
No.
sometimes when I want to give myself grace, I say, "This is my beloved body in whom I am well pleased." And I just want to encourage people to kind of like love their bodies, in spite of all the stuff that we go through with our bodies.
Well said. Very well
Yeah,
said.
agreed.
Yeah, you've only got one to work with. You do want
Yeah.
to
Right,
Uh,
right.
If anybody has any off the cuff questions,
Sure.
any quick ones, it was a son that is 49 years old, and he is a paraplegic, if I remember correctly. And her name is Christine, if I remember the name correctly. And she's been trying for 3 months to find a doctor willing to interpret his lab work. So, Dr. Tennant, do you have any recommendations on, or any notes on what a person could do about lab work that is hard to interpret, or a lot of times people are unable to get someone to order the lab work, and that it's a real problem. Do you have any suggestions?
Yes, I'm so glad you brought this up, because this is going to be a subject for a later session. Today, because of all this new research on pain, blood work really should be done. Now, I want to caution you one thing about laboratory work. Today, your insurance coverage may not pay for it. It's become too expensive for any normal person to pay cash. And so, from what my recommendations are, don't hold back on treatment waiting for blood work. Okay? Get started. Yeah, time is wasting. So I want to make it clear. I'm going to tell you the blood work I'd like to see, and I'll give you some ideas how to get it interpreted. Right now, the whole concept of parasitic autoimmunity and reactivation, particularly with the Epstein-Barr virus, is hot stuff. And I'm hearing from a doctor a day on what blood test to order, and then what do I do with them? How do I interpret them? So our foundation, we've got some stuff we just prepared to send to anybody, free by email or US mail or what have you. So there is blood work to be done. But let me explain, let's go back to Rhonda's visit with her doctors this morning. And let's talk about why a lot of people are having trouble. I had another patient this week, says I went to a rheumatologist and told him I had a TC arachnoiditis, and the rheumatologist says, oh, well, that's a neurologic disease. I can't treat that. You got to go to the neurologist. And then I went to the neurologist, and the neurologist said, oh, well, I can't treat that. That's a medical autoimmune disease. I can't treat that. So consequently, no one's going to take her. So we have, besides, that's why we like Dr. Ibsen on here and some of the other advocates, we keep trying to get regulations and rights, the right ability to get any medication you need for some of these conditions. But we also have the problem within the medical profession of the specialties. Okay, now let me explain just real quickly a little background on these things. The organized university medical training occurred right around World War I by something called the Flexner Report that came out of Johns Hopkins, and it created the university medical systems as we know them today. And after World War II, they got even more specific. In other words, today, the surgeons don't know a darn thing about medical treatment. The anesthesiologists are trained to be surgeons. They don't know a darn thing about prescribing. And today I was hoping Dr. Ibsen was going to come on because he and I were trying to do something about somebody who's had their pump cut in half. And that's the surgeon for you. He doesn't know that that's going to throw somebody into terrible heart problems and collapse and what have you, because they just have no medical training. Okay. On the other hand, today, somebody who goes through internal medicine practice or residency, for example, may not have any idea when you should go ahead and do that laminectomy or that fusion of the spine, because they don't know a darn thing about the anatomic problems that inflammation and autoimmunity may cause. So we have that basic thing. Now, the big one that affects us in pain management today, however, is the confusion about the word autoimmunity. Okay, autoimmunity. Unfortunately, I'm going to have to try to get everybody, including physicians, somewhat educated about what this term means and the pitfalls that have come about. Now, if you go clear back to the 1800s, it was recognized that infections, and it was called autoinfection, after you got tuberculosis or even a sore throat or pneumonia, you might have some disease that affects your back or your stomach or your ear or something after the infection, and they call that autoinfection. Dr. Coburn, Alvin Coburn, was the man who in the 1930s discovered that a strep throat could give you scarlet fever and rheumatic fever, glomerulonephritis, and rheumatic heart disease. So he is the champion among physicians in discovering that an infection can lead to what we now call an autoimmune disease, okay, after the infection, right?
Okay. Wow.
After infectious mononucleosis was identified, I personally published a paper in 1968, if you can believe this, in which after an infectious mononucleosis, a young man got kidney disease, glomerulonephritis. And that goes clear back to that time. But the big issue for us today has to do with the term autoimmunity. Now, after World War II, the profession or the specialty of rheumatology took root. Now, the term rheumatism goes clear back to the pre-biblical times, I believe. And rheumatism meant generalized pain in your joints, maybe the face, the foot, wherever. And so rheumatism meant pain all over. Still does, to some extent. But the rheumatologist took up the cause of autoimmunity. And medical dictionaries started to define autoimmunity. The first one I could find is 1961. Look up in Tabor's Medical Dictionary or Dorland's Medical Dictionaries in the early 1960s, and you will see that autoimmunity is defined as what's called an autoantibody that destroys your own tissues. Okay? Now, the kicker on all of this is the term autoantibody. Now, early on, researchers did some great research, and they found out that diseases such as rheumatoid arthritis and systemic lupus, Sjogren's syndrome, and maybe a couple of other rare conditions produced in the body something called an autoantibody. And a lot of you have probably taken a test for one. That's the rheumatoid factor. That's the lupus test.
Yes.
That Sjogren's has that test. Ankylosing spondylitis have that test. And they test for something called an autoantibody, meaning that the body has developed a protein, a globulin, that will attack your own tissues. Okay? Attack your own tissues. Now, the catch is, with such diseases as Ehlers-Danlos and some other diseases, acted like they were autoimmune, but they didn't have autoantibodies. So the rheumatologist didn't want the case. Most of them still don't. However, the new research, particularly with one study out of Cincinnati, it's a profound, great study, one that's changed my whole thinking about this. They documented that you could have an autoimmune process without autoantibodies. Now, you got to think about what this means. It means a lot of your rheumatologists out there don't want you. It's not a rheumatic disease if you don't have an autoantibody. Now, we've got to get everybody over this. We don't fully understand how it works, but the best definition for autoimmunity, and it's one that every constant pain patient needs to fully understand, and that is there is some element or process inside the human body that is causing tissue to degenerate and become inflamed and perhaps even cancerous or form adhesions. And we now know that almost all of the intractable pain or constant pain conditions have autoimmunity as one of their causes. Now, there is no medical specialty who specializes in this at this time. And it's not well understood. It's new to medical practice. And you pain patients are going to have to go do the educating. Okay? You've got a vested interest. And the medical profession is taking this hard. I'm going to be honest about it. This is an 800-pound gorilla in the room. All right? In other words, those surgeons who operate on spines or your hips, those anesthesiologists who do all those epidurals and all those people who do infusions, all those mental health people who think it's in your head and you need to reform your thinking, they're taking this whole concept of autoimmunity without an autoantibody very hard. Okay? They're taking this very hard, but it's very clear this is what's happening. And there were some studies in 2018 out of the children's and VA hospitals in Cincinnati, highly funded by the government, a few dozen researchers, hard data, and showing that an autoimmune process without an autoantibody might cause multiple sclerosis and type 1 diabetes, perhaps, celiac disease, maybe some of your bowel syndromes. Sjogren's syndrome, some of these conditions don't have to have an autoantibody. And we've just finished our studies of 110 patients showing every one of them had high antibodies, but no autoantibodies. And so most of your constant pain problems are autoimmune, meaning there's some element or process in your body eating away at you and causing inflammation and deterioration and knocking out your transmitters or your small fibers, but you don't have autoantibodies. Now, what doctor is going to treat that? At this point, it's the doctor who gets interested. There is no specialty that's going to take this at this point. So what I'm recommending to everybody is for you to start understanding it and ask the doctors for help, but don't just depend on that doctor to do it. Every day, there's not a day goes by, I don't get a request. Would you tell me a doctor who specializes in RSD or Ehlers-Danlos or arachnoiditis in upstate New York? What? I need a doctor in lower Michigan who treats adhesive. There is none. Where is the doctor in Florida who treats these conditions? They don't exist. Okay? So you've got conditions, you've got constant pain, you fall through the cracks. There is no medical specialty who wants you. Dr. Fogg, the doctor in the 1700s, he was right. If it was persistent and complex, nobody wanted you. It's still going on today. So, but I want to make you aware that this concept of autoimmunity is kind of throwing the medical field into a tizzy. Okay? Nobody understands it too much. It's new, it's different, but the research is well backed up. And of course, you're going to hear about the Epstein-Barr virus. That's the big elephant in the room. And it's a virus that causes 2% of the world's cancers and causes a lot of these other things. And the Epstein-Barr virus, incidentally, can be boosted by Lyme, COVID, herpes 1 and 2, cytomegalovirus, what have you. So these viruses can gang up on you. Okay. And so we're going to talk a lot about it, but that's really the aegis of the inflammation inside the brain, inside those small nerve fibers. It causes a lot of entrapment. And so this is kind of new, but it goes back to the practical point that we don't have a doctor in every community who even understands this, much less knows how to treat it. Now let's get to the blood work. That's how we started out this conversation. If a patient, and I've got a little, I'll be glad to send this to anybody. I'm recommending that you take if you've got constant pain, there are 3 classes of blood tests that I highly recommend, if you can get them through your insurance. You can't, they're too expensive to pay for. The first one are the Epstein-Barr markers. Now, LabCorp, Quest, and your big labs now all do a 4-panel Epstein-Barr antibody panel. Now, in my opinion, in order to get the right treatment for not only adhesive arachnoiditis, but RSD and some of these other conditions, you need that 4-panel. The catch is a lot of your doctors aren't going to know how to interpret it, but we can teach them. It's easy. There's none of this so difficult that a smart 5th grader can't understand. If you can educate 5th graders, doctors have a shot at it. So we'll keep working with that, okay? All right, the second class of blood tests you need is a hormone panel. Now, constant pain patients need 3 hormone tests, 4 really. One is pregnenolone. The second one is DHEA, that's dehydroepiandrosterone. The third one is testosterone. And the fourth one is cortisol or cortisone. However, the cortisone will drop down if you're already taking cortisone. Don't bother to take the test. Now, there's a lot of other hormone tests you can take, thyroid, estrogen, insulin. You can take a lot of tests, but the 3 that are relevant to pain and regeneration of tissues are pregnenolone, DHEA, testosterone. Those are the big 3. And those are ones that everybody watching this should have that panel test. You could get it every 6 months. Now, the third class And you've heard me talk about cytokines in the past. Well, now that's actually progressed to where
Yep.
there's only certain cytokines, and they're called interleukins, that we like to test for. And there's about 4 of those. Now, all of the laboratories have developed an interleukin panel. Now, the major ones we look for have numbers. They're not going to mean much to you, but they're 6 and 8 and 10 and 2. I mean, there's 3 or 4 that are really key. 6 and 10 are the 2 we want to look at the most. If you can, and if your doctors will order them, you want to get that panel. Why? The interleukins tell you whether that autoimmunity is causing inflammation. Okay, out of hand. So if you can get it, we need your Epstein-Barr titers or hormone antibodies. We need your specific hormones, and also we need your interleukins. If you can get any one of those 3 panels, great. They're a big help in knowing what to do about the conditions. But if you don't have insurance and the ability to get these done, or no doctor order them, don't hold treatment back. You go ahead and get started with your 3 panel components. I want you and Rhonda I want to change the subject for a minute. I know I've talked to both of you about this, and something I feel very strongly about.
Okay.
We know that these conditions I'm talking about are not curable except in rare situations, rare instances when we can catch the disease real early and do something about it.
Yes.
A lot of you have suffered for years. Nobody knew what you had. I think we had somebody on the show last week that went 20, 30 years, no diagnosis. And we have people like that. Okay. But what I want to talk about here right now is that I realize that I've been talking a lot of science here now. It's complex. I'm aware of that, but I do think you have to know it given your serious condition. Now, with these serious conditions that all of you have, you're disabled, or you can't work, you can't do a lot of things like you used to. And what on this show, many times we've talked about people's spiritual connections, about their prayers, their life. Jamie and Rhonda, I'm going to ask you guys this. You guys, frankly, I don't know why you're alive. I know a little bit about your cases. You've made it through a lot of your spirituality. What have you guys done? I want to hear not only from you, but what do you want to ask everybody else out there about? How do you get a quality of life given the seriousness of your disease? How do you stay in touch with a God and your people to stay alive? Okay, my medicines are going to help, but you got to have that spirit.
Yeah.
You got to have a God, and you got to have a lot of willpower to live through this CRAP. Okay.
Yes, I
Yeah.
agree. Rhonda, you want to go first? That's a great question.
I will follow you, Jamie. I've
Okay.
had a moment to talk,
All right.
so you take it away.
Okay. I want to say that I think that the time that I really called out the most on God when it came to being in the middle of suffering was when I was hospitalized for 4 straight months, 115 days. And I had a lot of time to think and a lot of time to pray and a lot of time to really question life and questioned him. I wrestled with him a lot. I don't recommend that. I never won that wrestling match, but I do have to say that it gives me hope that this isn't all there is to life, is just to live for a few years. And some of us may suffer through, some of us may live for 3 years, some may live for 103. But I think a big thing is the way that we love each other, along with having faith. It really does, it opens up a lot. I know that there are so many questions that we have, and there have been so many times that I've said, God, where are you? And I remember just recently, I said, Lord God, please help me. I remembered the scripture that said, I am. So when I said, please help me, that scripture, I am, came to me. So that's been my only way that I've made it through, on top of on the science aspect, is I don't think I could have I don't think that I could have made it through this, the pain, the agony, the besides all of everything being so perplexing, then you have the stigma, and then you have public opinion, and then you have people that really don't understand. It's a big uphill battle, and it will make a warrior out of you, if nothing else.
Yep. I've got another question and a thought for you. I've had a number of disagreements over the years with people who say, well, all those intractable pain patients are just hanging around in bed, taking all their medicines. They don't do anything for society. They're totally unproductive and really ought to go.
No,
Okay? My answer has been real simple. You don't live very long if you're not doing something else, just doing something good for someone else. Okay? And I've talked to people all the time, and they say, well, I'm really not doing much for anybody. Then I talk to them, and I find out all of a sudden, no, they're talking to their grandkids every other day. They're visiting with somebody. They're reading something, or they're doing something for their church, their neighborhood, their family. They're doing something. Give me your thoughts about that. Of course, you guys are very dedicated to humanity and trying to help and care, but I think that this idea that nobody does anything for anybody else is the biggest bunch of hooey I ever saw. You don't live long if you're not. If you're just that selfish person doing it on your own, you're out of here pretty quick. Particularly if you got arachnoiditis or RSD. So give me your thoughts about that, Rhonda.
Well, you're absolutely right, Dr. Tennant. Going back to the beginning of all of this, and I could not see like what is the purpose of all of this. Just all of a sudden struck down with something that I didn't even know what it was at first until you. What is the purpose through all of this? Well, as you go through this path, myself, I'll just say me, as I went through this path and I started learning from you, and I became active on social media where I was not prior to. I didn't have any social media account prior to my all of this going on. I was too busy. It slowed me down. I've met some of the most incredible, warm-hearted, genuine people that I have ever in my life been blessed to know. Dr. Tennant, you're at the top of that list. You've saved my life, and everything you have done for me, I want to be able to turn around and give back to other people. It's my way of paying it forward. What you've taught me, what you've given me, I want this for every single person that I come in touch with. So that's what I do besides gardening, and grandkids and family, but that's what I do. That's what feeds my soul.
Yes. Yes.
To wrap us up today, no, you don't have to do everything alone. There's a lot of groups, a lot of families, a lot of ways to join these days. Social media has been a godsend, in my opinion, for a lot of people who are bedbound and housebound.
It is.
Yeah, you don't have to go it alone, but that joining a group is one way you give back.
Yep.
Okay, so now don't try to do everything alone unless you have to for a while, and something like that. You have any other? And let me close out with this. When people do feel that don't feel they're contributing anything, and they're sick and they're wore out, obviously they think about ending their life. You have any last thoughts here about recommendations as for that person who's in that situation right now, today? They're thinking about the end. They're taking their life. What's your recommendation?
I would like to say something on that.
Sure, Brenda.
My father took his life when I was 2. 2 of my brothers, 2 of my sisters have all taken their life. There were 7 of us. My mother buried 6, one at a time. I got to that point not too awfully a couple years ago. Jamie talk to me. I was thinking maybe my brothers and sisters and my father knew something I didn't know. I fought all my life to keep fighting and to keep living.
Mm.
And I got those deep, dark things where nobody would help me and, you know, whatever. Anyway, what I need to say is trust in the Lord. He will not leave you. He will not forsake you. No matter how deep down, dark you get and your thoughts are, there is going to be morning. There's going to be light at the end of that tunnel. That's all. Thank you.
Well said, well said. Last comment, anyone? If not, I will sign off. Again, we've had a scientific session here today, but don't forget, there's that man upstairs, there's a lot of people around, there's a lot of goodwill to be done. Thank you for
Yes.
being here, and we'll see you next week.
Thank you.
Thank you.
Thank you,
Dr.
Dr.
Tennant, I do want to
Thank
add
you,
one more
everybody.
thing. I just want to add one more thing is that it is truly like medicine when we can reach out to another person and turn a frown upside down. So smiles are contagious. And if you can
Yes.
just be a friend to somebody, like Rhonda said, paying it forward, that's the way to do so. It's just be a listening ear. That may be what that person needs. It might just be all they need is to know that someone is out there and that they understand.
They just
So-
listen.
Mhm.
Well said, Jamie. Yes.
If Dr. Tennant's still here, I did have a question for him, but if he doesn't have time, I understand.
Let me double check for you, Amelia. I think he might have already. Yeah,
So I think he jumped off.
yeah. But it's
Yeah,
been
well, I
such-
mean, I can even ask all of you, you know, if you've
That'd be great.
experienced this. So I'm running into problems with my PCP pretty much wanting to do anything for me.
Great.
You know, and I know he's retiring and I know that that's probably a lot of it, you know, he just wants to be done.
Mhm.
But like, if you all come across this where, you know, you're requesting referrals to different places or, you know, like, or a medication like pentoxifylline and they won't do it. They said that she said that she wanted to see my next MRI before they were about to prescribe pentoxifylline. And I asked her why, because I had submitted all the proof she should need that I have adhesive arachnoiditis, you know, and along with Dr. Tennant's protocols.
Do the MRI, because what they do, what that doctor needs is the MRI ordered by them with their name on it. That
Gotcha.
protects them.
There you go.
Mhm.
Because I just had 2 done today, my thoracic and my lumbar.
Oh,
at
wow.
the same time. It was a new doctor.
Mhm.
I just started this. Jamie can vouch for this. And Jamie's right. If it wasn't for Jamie Sanchez, we could talk and talk and talk, and we can make each other feel so much better for just having a conversation. If she just start out, she'd have a, you know, you can tell Jamie's like down or feeling of a hopelessness, but after we get done with our conversation, it's like the Holy Ghost then took over us and then lifted up our spirit so high that no one can take us down. No.
Jamie's wonderful.
Mhm.
Jamie's wonderful.
Grace.
Yeah, and so I actually did go to the ER yesterday. The reason being is
Dude.
because I lost bladder control. And so, you know, the new spine rehab doctor I've been seeing, that was her recommendation, go to the ER. And, you know, I felt like the only benefit in doing that was because my doctor had, through that health system, had already placed an order for an MRI for me with contrast. And I was not happy with this resident doctor because he was questioning why she ordered it with contrast, and he did not do it with contrast. So
That's odd. Yeah.
Yeah. Mine was not
I-
done with contrast either, but just try not to get upset. Once you
I
show
know.
upset and hostility, I mean, it's like the golden rule Dr. Tennant taught, do unto others as you would do unto you, and speak with that doctor the way you would like to be spoken to. It's not his
Yeah.
fault because
yeah.
and the AMA even came out and said this a few years ago. By 2025, 85% of all medical doctors will be retired out because they're burned out and they're tired of the insurance and government dictating their health care. Now, I had a friend who went to school where I went to high school out who is an MD. And said, if I'd known this is what's going to happen, I would have never became a doctor because I can't practice medicine the way I was taught to practice medicine because of insurance and oversight of the government.
Yeah.
And that's being honest.
Yeah, I truly believe that. Yeah.
That's why they're leaving.
Rhonda, did you have something?
I did have a question. What is the problem? Why is your doctor having such an issue prescribing pentoxifylline?
I don't, well, so this is what she said. She said, I'm already on a Fexer, an antidepressant, only 150 milligrams, which she said can have the potential to cause bleeding. From what I read up on it, it's very, very rare. She's also said the pentoxifylline has the potential to cause bleeding, and that, they would just have to find out the correct doses and everything that I need, which I already sent to them, from what Dr. Tennant had recommended. So, yeah, I don't understand. Fortunately, I have another very, very gracious doctor who was willing to prescribe pentoxifylline.
Sometimes they are.
No, y'all can see
Sometimes
this
there's a
book.
concern about medication interactions. Sometimes there's a concern about liability if there's a GI bleed. But I could see if 2 or 3 medicines were prescribed and all 3 had that chance or that risk of bleeding in the stomach. But I just maybe she's just trying to protect you, but it sounds more to me like she's being
I think there's more to it.
and protecting herself. But yeah,
because I even checked with my pharmacist, my local pharmacist, and they said there's absolutely no interactions between any of the other meds that I'm taking.
Exactly.
Good. And
Yeah.
Dr. Tennant says that this is an old school medicine.
It's very safe.
That doctors should not have a problem with it. So
that's it. That's right.
Yeah.
It has.
Okay. Vincent says it interacts with ketorolac, and he is correct. There is that chance. However, I am one of the lucky people. I don't know, but I've been taking ketorolac and pentoxifylline since day one and seeing Dr. Tennant with no issues.
Yeah.
Wow, that's great.
But that is correct. It can interact with ketorolac.
Yes, I think the key is though that if it's that intermittent dosage, like the once a week ketorolac or the
Jamie.
Right,
rather than every single day of both medications, that would be, I could see being worried if it was every day of both meds that you're taking NSAIDs 2 or some other. But if it's taken the way that Doc has suggested on an intermittent basis, it's truly, I think it's safer than the 800 milligrams of Motrin I was taking Q8.
I definitely agree.
Yes.
Oh yeah.
Definitely agree.
Yeah.
So 5 years of that was enough to do.
And ibuprofen, you will not get the relief. I don't care how much of it, you're not going to get.
Nope.
Because ketorolac crosses that blood-brain barrier, and that's what you need to target that neuroinflammation inside the spinal canal to drop that pain down and help prevent the progression of the disease.
Yes.
So,
well, guys and girls, it's been a great evening. I apologize that happened with Denise, and we hope that something can work out. We've got Julie on
Yeah.
coming on next week and looking forward to that. And we've got some more special guests coming in, but you are all, of course, special guests as well. You're the family too.
So are you, Jamie.
Thank you. Glad to be part of the family.
Thank you so much.
I
Love you,
need
Jamie.
you.
Thanks so much.
Love you all.
Thank you all so much. Bless
Yeah,
you.
thank you,
Much.
everyone,
So much.
Not alone. It's been
for
great
all
to
your
be with you all.
Bye, everyone.
insights and
God
leadership.
bless.
Thank
See
you.
you
Jamie.
next
God
week.
bless
See you
everybody.
next
God bless
week.
you all. See y'all
Thank you.
next week.
Too.
Have a good
Bye-bye.
Have a
evening.
good evening.
Allison,
Good night.
Bye-bye.
it's so good to see you,
Night.
Allison. Stay alive. Everybody
Yes.
stay
You
alive.
too.
Please stay alive.
Amen.
Everybody stay alive. We got this. Even if we have to live for 120 years, and we're not going to, that's really not a long time if you think about it like that.
We
But,
can
all
make
right.
it to 120.
No way. So,
Yeah.
No.
I'll be
Buddy.
Bye-bye.
178. I think. I'm not sure. Bye.
Good
All
night.
right.
For your,
Good
Bye,
night,
y'all.
or your
everyone.
uncle says, I feel like
Checking out.
the elders, when they speak, say I'm 84.
Yeah.
And it's like, but no, I'm originally 48. You know how they'll
There you
say
go.
that.
Yeah.
I said, oh,
Yeah.
Uncle Bobby, I'm 48 and I feel like I'm 84.
Yeah.
There you go. There you
Oh
go.
my gosh, do I hear you? Yeah.
There you go.
Totally get it, right?
Oh yes.
Oh
yes.
yeah.
All
Love
right.
you guys.
Absolutely.
Love you too. Good night,
All
guys.
right. Love
Good
to
night.
all of you. Have a
Love
good
you all
night.
too.